Screen. Good. So, hello everyone. Good afternoon, good evening, good morning. Some people I think are pretty much zooming from tomorrow. We're very happy to be here today and to have you here today with us for the Linguistic Justice webinar. And it is a great joy and delight to welcome our two presenters, Nicole Marinaro from Ulster University and Cecilia Gialdini from the University of Edinburgh. Few words on our speakers today. So Nicole's work focuses on the management of communication towards minority language speakers in the public healthcare sector. And Cecilia's work focuses on language policies, intersectionality, and social justice. The paper they will present today is entitled Linguistic Justice in Healthcare, Macro and Micro Perspectives. As per usual format, we will begin the presentation, which will run for about 40 minutes. We'll then take a 10-minute break and then reconvene for the discussion for another 40 minutes or so. The presentation itself is being recorded and will be posted on the Linguistic Justice website YouTube channel, but the discussion part is not recorded and will not be made public. So, if all sounds good, then let me hand the session over to our presenters, Nicole and Cecilia. We're thrilled to have you here today, and the floor is yours.
Thank you. I'll start. Start this the first part of the presentation. I just said that there might be sirens, and of course, sorry for that. Yeah, so we're delighted to be here to be part of this webinar series, and as Yael kindly already introduced us, we're going to talk about linguistic justice in healthcare. And more specifically, we're looking at two different perspectives or point of views, both not only like the way we see linguistic justice, but also the way we use disciplines to understand linguistic justice and language policies. So in this first part, I will talk about the macro perspective, which is going to be focused on the state. So what do government do or don't do in terms of language choices, which are framed as language policies. And more specifically, I'm going to talk a little bit about my thesis, so how we can evaluate the language policies in terms of linguistic justice, specifically looking at what's the impact that can be on access to healthcare. Then we will move to Nicole's part of the presentation, where she will look at things for a more sociolinguistic perspective and talk about linguistic unease and linguistic justice from a subject-centered perspective. So looking at the experience of the speakers and how can this inform language policies. So as I said, this is my part. I have a PhD in social policy. I go a bit between sociology, political science. So my perspective is a bit interdisciplinary. And the focus of this presentation is going to be mostly on social policy and public policy, but I'll get more into that in a minute. First of all, what's the role of the state in language and in access to healthcare? So first, I just wanted to mention that this is by no means a new or a novel topic, as the access to healthcare and the issue of language barriers has been widely studied in the literature. There's been contributions that have spiked during and in the aftermath of COVID for obvious reasons. So because it was one of the most, the biggest healthcare crisis that we have seen in modern years. But that doesn't mean that the topic came about with COVID. Nicole will talk about, we'll talk more about healthcare and language, but that's something that has been in the works for a while. A lot of studies are focused on interpretation, translation, and access to healthcare and everything that has to do with accessing healthcare through communication, through verbal communication or non-verbal communication and language. So Language and health are part of what we can define states, social policy and planning. They are a bit at the intersection of different parts of the state action. So it's the broader sphere of social policy, but it is language and what I'm looking at more specifically, and what because I think it's really, I see that there's Michele Gazzola as well on the call, so he'll know very well, and maybe he can give us his contribution in the discussion. But there still aren't a lot of contribution in the field of evaluation of language policies, and specifically language policies in healthcare. A lot of studies that are focused more specifically on single issues, but not on policies as a whole. As I said, this is an intersection of different social policies. So we're looking at healthcare and we're looking at language. And again, Nicole might have some more insight because this is in her line of work. But in general, we can identify a series of issues that come about when language is not taken into account in accessing of healthcare. Anything that comes from incorrect diagnosis. There is a higher rate of dropouts, of lower client satisfaction. This is particularly true in mental health care. So patients reach out to doctors, but then they do not feel like they've been heard or understood, so they tend to drop out before the treatment is completed. Similarly to this, there's poor adherence to the medication and treatment. In this sense, the fault in the communication, it's more that there's not enough understanding of what the treatment is actually about, and that results as well in not only interactions with medical doctors or nurses, but also with pharmacists. So it's the healthcare system as a whole, not only, as we might imagine, the issue being between patient, doctor, and maybe an interpreter. It's way broader. Also, as brilliant paper from Yale, language barriers exacerbate also what is defined as epistemic injustice. And this contributes to higher rate of medical errors, serious consequences for patient. Why am I saying all of this? Just because it is important. That's why we're looking at it. It has very serious and very real consequences for people. How am I looking at, though, not as I said, much as from the patient's or speaker perspective. I'm looking more at what the state is doing and what they should be doing, and how we can assess what they're actually doing. And in this sense, I use the framework of language policies as public policy. If you're familiar with policy cycles in general, we define decision-making by the governments as being a five-step process. So from the emergence of a problem, the conceptualization itself of the problem, then there's the recognition and the taking action. These are defined as agenda setting. Then policies are formulated, and this can be influenced by several factors that are political, but also historical and cultural. So government take decisions based on a series of determinants. And then there's the implementation part. So how these policies are actually made into practice. And then the final part, which is what I'm more interested about, is how we can assess if these policies or these practices were effective and were fair, and how can we do better next time, or how can we change them. There are some very important pros in this sense, in this considering a public policy approach. So it makes the assessment of fairness in language choices very straightforward. As I said, like, it's a five-step process. We can identify the actions of decision makers at every step and intervene. In one of the cons is that we might lose a bit of the grip on what is the individual's perspective. And I'm going to explain how I personally try to overcome this and try to make the process of evaluation a bit closer to the speaker by using the capability approach. And then, of course, Nicole is going to talk about her perspective as a sociolinguist that also helps us combine these two perspectives together. Yes, so in my framework, I look at linguistic justice, which is defined as a parameter to assess fairness of language policy and planning. As I mentioned, I'm using, I've used in my thesis, and I'm trying to continue on that, the capability approach. I'm very aware that there are a lot of philosophers here who are way more familiar than me with the philosophical underpinnings of the capability approach. So I'm not gonna delve into too deep into the concept. I'm just gonna say how I'm using it in line of measuring. Again, I just want to mention that this is not by any means a new idea. There are actually, I'm very lucky to build on a series of contributions, and the ones that I've listed here are not even conclusive because I was made aware that there are some new articles coming out, but I'm listing this because those are the concepts that inspire the way I conceptualize language and the language-based capabilities and how I can measure them. So in particular, I look at the idea of capability deprivation, that is what it was developed by Andrew Shorten. And a lot of my work on how we conceptualize language-based capability is actually based on the work of Sergi and Nicola and Nico Brando. They did, if you have the chance to read it, their paper on the language-based capabilities in the framework of the essential capabilities of Martha Nussbaum is really, really interesting and a good part of my thesis. So thank you for that. So in a nutshell, as I said, I'm not going to go very much deep into the approach, but I'm very mindful that there might be people here that have no idea of what the approach is. It was created as a sort of a response to the prevalent utilitarianism perspective in economic studies. And the idea was to merge individual center and environment as a government and an institution center perspective to create a conceptualization that well-being that was more holistic, was broader than just the idea of resources. So I need resources in order to be happy. I need resources in order to be in an optimal state of health. So well-being is defined as a set of beings and doings that the individual is or does, and a rich and fulfilled life constitutes the possibility of turning these capabilities, who are potential opportunities, as the series of all the things that one can be or do into actual functioning. So something that it's actually tangible. And this is really crucial because it takes into account the personal preferences. So something can be available, but the individual person, like the person, might not be interested in that particular thing. And this is very crucial when we talk about language. And my former supervisor, Brian Carey, talked about this in the preference model system. So it's important to give speakers the possibility of use their preferred language, but we're not forcing them to choose one or other language. This is really important, again, in the way I conceptualize language-based capabilities. In particular, I want to focus on what are defined as the factors that influence this transformation. So all the sets of social, personal, and economical, environmental determinant that allow a person to turn a capability into a functioning. Why am I focusing on that? Because that's where the role of the state becomes crucial. So in a just society, as what Sen defined it, the state is the actor that eliminates the barriers. So they do not intervene singularly in the choice of the individual, but they remove all the barriers so the individuals can choose to turn certain capabilities into functioning. what it doesn't mean in terms again of linguistic disadvantage and capabilities. We define linguistic disadvantage as a mismatch between repertoire and environment, and characterizing it as a capability deprivation in the approach that I take, it means that there's a conversion problem, which means that there are some sort of obstacles from a social or a personal perspective that do not allow individuals to turn those capabilities into functioning. I can go more discussion, but for what we need now, this means that I define language-based capabilities as those capabilities for which language is functional to the conversion of the capabilities itself into the functioning. They're not necessarily bound to language. For instance, access to healthcare is a capability that can be vehiculated through language, but is not necessarily related to language. We're not talking about the right to speak one's language. So the capability-based linguistic justice is defined as a social environment where individuals can freely transform whatever capability they want into actual functioning. And in this definition, the state or a just state is an environment where those potential communication opportunities are actually enjoyed. And again, I'm using this as a very practical framework to then evaluate the performance of the state, which means that all of these language-based capabilities, which is ideally could be extended to anything that is related to communication, have to be narrowed down to essential needs and essential public goods and services that the state has the duty to provide for the citizens and the residents. I'm telling this because you will see from the table that I'm presenting now that the list of essential capabilities that I have identified is very short compared to all the potential communication opportunities that an individual has. And this is derived by two reasons. One is practicalities. We need to, when we measure the performance of the state, we have to draw the line somewhere. Otherwise, the more we expand, the less feasible it becomes to actually assess what the state is doing. And also because the ones that I have identified respond to the idea of fundamental services. Of course, we can always build on that. But for this minimalist approach of assessing linguistic justice in the state, I think this served the purpose. So dimensions of linguistic justice. In my thesis, I have used the constitutional approach developed by Berkey, but I'm not, again, I can tell you more in the discussion, but I don't think, I'm afraid I don't have enough time. These are the essential dimensions that I have identified, which correspond to essential language-based capabilities that can be easily converted into a public good or service that the state erogates or provides for the citizen. So we have a level of control of the state, which means that we can actually see what they're doing. In terms, for the purpose of this presentation, I really want to focus on access to healthcare. So of course, health is considered an essential dimension, and the language-based capability is access to healthcare with no discrimination, which means being able to access healthcare services in one's preferred language. From these dimensions, how do we turn into indicators? So my project was to operationalize this definition of the linguistic justice to make it into something that can be measured and in different states and in different jurisdictions. So I've developed a series of indicators based on availability of data. So my main focus was to have data that was already available. So only secondary data, which means that the comparison can be done without having to initiate a whole research project. They're material that can be very easily accessed, so they don't require any fee. They're material that are more or less the same at different jurisdictions. Maybe they are catalogized in a slightly different manner, but they are very much universal in their meaning. And then I normalized. So the idea was to assess the present. So present or not of this data was yes or no, then the yes or no was expressed in a binary form or 0, 1, which means that we are also able to have some statistical analysis. Again, this is the full list of my indicator, but I wanted to focus on the healthcare one. As I said, I'm taking a very essential approach. So of course, there's a lot of services that could be analyzed, but in the framework of assessing at least the minimum level of linguistic justice of a state, I'm only looking at emergency language planning and general practice or basic medicine. This is named differently in different countries. It basically means the primary healthcare, what in the UK is called as the GP, the general practice. Going more into detail, what are those indicators measuring? So first of all, the emergency language planning, which is indicator 1, is the availability of communication in multiple languages, in the languages that are spoken in the countries by a variety of linguistic minority. I haven't mentioned here in the presentation, but of course, when I talk about linguistic justice and linguistic minorities, I am referring to all minorities to the likes of international conventions and treaties, but also the new minorities derived by migration fluxes. So emergency language planning, everything that prevents epidemics. So during the pandemic, that was pretty much anything that was directed to the prevention of the spread of the coronavirus. But this can also be interpreted as the spread of seasonal viruses such as influenza or flu. More broadly, sexual education, such as all the information to prevent the spread of STD and STIs, or more, this depends more on the health situation of the single countries. There might be specific risks derived by the geographical determinants. So prevention more generally of spread of diseases that are a risk to public health. And as I said before, general internal medicine, which practitioner or family doctor as they're defined in various countries. And just my final minute, I'm sorry, Nicole, I went a bit overboard. Yes, if you're interested in my research, I have an article based on my dissertation, from my PhD dissertation, that is supposed to be published in the next days on language problems and language planning, or email me, I can give you a copy as soon as I have one. Yeah, where we can talk more about language-based capabilities during the discussion. And thank you so much for listening. And now over to Nicole.
Thank you so much, Cecilia. Can you all hear well? Is the mic working well?
Sometimes when you lean back, it cuts in and out. If you could just
no leaning back then, just leaning forward. Okay, well, thank you so much, Ceci, for this great presentation, and thank you for having us. Thank you all for being here. And I will now talk about the more micro perspective after Cecilia brilliantly presented the more macro perspective, or one of the macro perspectives that could be adopted. So I would just like to start with this quote, which I think is a very effective sum up of the kind of issues that can come up. And I will now very, very briefly get into them. Cecilia already introduced this a little bit. Unfortunately, I'll have to sum this up very much. But there is really a wealth of literature that suggests the kind of issues that can come about if there are communication language barriers between patients and healthcare providers. I listed some of them. This is not an exhaustive list, but as can be also intuitive, if the doctor cannot properly communicate with the patient, there may, for example, be issues with, reconstructing the medical history of the patient. Patients have been shown to not adhere to treatment, as Cecilia was mentioning. This can lead to unnecessary medical exams being run. And of course, patients will have less trust in the healthcare system and try to avoid to resort to care or do so too late. And it's also an issue in terms of the lack of true informed consent, which, however, is a right of the speaker. Again, very briefly, sorry for the long quotes, but I thought these were very effective in explaining, again, the issues and the added layers of complexity that can come with communication barriers in the context of mental health care specifically. So as Bauer and Allegria in their brilliant review explain, language barriers can not only lead to the patient not being able to express themselves as effectively as they would need to, but also to the practitioner not being able to identify disorders that may be evident in the speech of the patient, as well as then, of course, also representing an obstacle for factors that contribute in the process of care and of healing. And again, unfortunately, I'll have to say this very briefly, but we could talk about this for hours. The case, and as I will explain later, I look both at the case of migrants and at the case of minority language speakers of an autochthonous minority language. In the case of speakers who speak an autochthonous minority language, but are also bilingual in the majority language of the state that they find themselves in, their linguistic needs are often invisible, in the sense that they're just thought to be able to adapt to the majority language, and it's thought often that they should adapt to the majority language, but there is actually a whole range of issues connected to this. Not only could even quite proficient bilinguals struggle in some cases to express themselves, so much so that they could even lose fluency in their second language, especially particularly vulnerable groups, persons affected by dementia, young children, etc. But also those who do not lose fluency may still really struggle to express themselves. As well as, of course, this impacting their sense of trust and connection and the bond that is established with the practitioner. So here we see both communicative and symbolic issues, and I will come back to this distinction in a couple slides. So just to give you a brief idea of the wider study in which, from which these considerations that I'm presenting today come. So my PhD aims at evaluating the design of policies, of public policies, that target language barriers in the access to healthcare, as experienced, as I mentioned before, by patients who are either migrant persons who therefore do not speak the language of the country, of the host country yet, or minority language speakers of an allochthonous minority language. And the three regions I'm looking at are Northern Ireland, where we are now, South Tyrol, and Catalonia. And I won't get into the whole methodology of the policy analysis now, and the evaluation of policy design, which is what I focus on. But just to give you an idea of the overall mechanism, basically the final goal of the policies, which is then also the starting point of that evaluation, is conceptualized in my study in terms of linguistic unease. What is linguistic unease? I'm here again, sorry for the long quotes. I will talk you through it briefly. I'm using Jan Nakaro and colleagues' definitions. These are papers, the papers in which the concept has mostly been developed, although it was originally proposed by Giovanni Agresti a couple of years before. Basically, a situation of linguistic unease is a situation in which the linguistic knowledge in terms of both communication or symbolic values that a speaker attaches to their language variety is misaligned with the varieties spoken and the symbolic values spoken, used, of course, written, signed. When I say spoken, sorry, I mean all of them. So let's say used by the society around them. And some classic examples here are, for instance, an Arabic speaking patient in a hospital in Italy where there is no common language shared by, nurses, doctors, administrative staff, and the patient. So we have, a language barrier in the most classical sense. There is no way in which these persons can understand each other. And then in terms of the symbolic dimension of linguistic unease, an example could be a Welsh speaker who, as we said before, may be bilingual in the majority language, which of course would be English, but it is symbolically, in terms of identity, it is to them very important to use Welsh as is their right in a healthcare encounter. And if this symbolic value is not recognized and this service is not provided, this can lead to symbolic linguistic unease. And just to briefly elaborate, a bit more on these two dimensions, probably these concepts are quite familiar to most of you, but just very briefly, the communicative dimension refers to language being a tool to pass on a message, and the symbolic dimension has to do with the identity value of language. Of course, political theorists, philosophers have written a lot of incredibly interesting contributions in this regard. And I would just like to echo here what Jill writes about communication and identity, the communication and identity value mattering to the speakers of every language. So there is no languages, although that is a common misconception, that has only symbolic value, and no language that has only communicative value. All languages have both. And this really matters in terms of linguistic unease, because linguistic unease, although I have presented them in a very binary way in my examples, but actually linguistic unease is never completely communicative or completely symbolic. It's usually both things, maybe at different levels. Maybe it can be a very high degree of symbolic linguistic unease and a lower degree of communicative linguistic unease. They can both be high, etc., etc. So basically, the idea behind using linguistic unease is that examining the patterns of linguistic unease can help us to first identify and hence target the level of what Jan Acker and colleagues call sociolinguistic justice. And as Agresti, who I mentioned as the first person who wrote about linguistic unease, emphasizes, we take a subject-centered perspective, hence the micro part of this presentation. But it is impossible when we try to kind of operationalize and systematize the concept to take into consideration the perceptions and reaction of every single speaker, because of course every single speaker, even within a community, is their perceptions can very much differ. Therefore, we can only infer their possible reactions. And in order to no worries, sorry, there's a little rabbit going around here. So sorry, in order to then come to a systematization of linguistic unease, which is what I would like to share with you today, we need to build on this inference of the potential perceptions in different scenarios of speakers. And in order to come up with these scenarios, I combine two, we have to think of two elements, two main elements. One are sociolinguistic factors, and one are the linguistic services that are available in a specific context. I hope this isn't chaotic, but I'll try to explain it. So basically, the social linguistic factors, which I will now elaborate on, are a kind of lens. We have to imagine them maybe as a pair of glasses that we use to then, through them, see the single scenarios that we're considering. So they need to be considered simultaneously, kind of overlapping. So the sociolinguistic factors, of course, there is a wealth of sociolinguistic factors that would need to be considered, but I isolated the ones that I felt were the most important ones. Of course, this is very arguable and very much work in progress, so I'm happy about any feedback about this. But the three main factors I'm looking at are language attitudes, mutual intelligibility between the participants in the interaction, and the expectations that speakers themselves have about language rights. Why do these matters? Here, I just tried to summarize the expected potential outcomes of these social linguistic factors in terms of linguistic unease. So this is something that is probably very intuitive, but negative language attitudes will, from the side of the doctor, will probably lead to a higher symbolic unease experienced by speakers, a lower intelligibility, which can comprise a wealth of possible scenarios, can lead to a higher communicative unease. And again, they're also kind of interlinked. They're not really divided as much as we sometimes think. And also the expectations about language rights, and these expectations being potentially frustrated, again, leads to a higher level of symbolic unease. These things need to be, we need to remember these when we then think about the scenarios that have to do with the linguistic services. So very briefly, in terms of linguistic services that we can offer that can be offered to patients who experience, linguistic unease or communication barriers, however you want to conceptualize it, are firstly the employment of language concordant staff that has been shown to be the best case scenario, the best kind of measure in order to address both communicative and symbolic needs. This is then followed by, in terms of how positive the consequences of employing this measure is, by the employment of interpreters, professional interpreters. They can be face-to-face, telephone, video call, that depends on the kind of setting and needs. In terms of ad hoc interpreters, which are basically untrained interpreters, maybe family members, maybe even a stranger in the waiting room. There's a whole wealth of possibilities. Confidentiality and ethical issues are very prominent, so this is something that needs to be considered. And of course, even when we have bilingual providers or interpreters, there is a number of further challenges to consider, such as their proficiency, their actual level of language proficiency, their language attitudes, again, the kind of training they underwent, is there any potential maybe ethnic contrast with the patient, and in general, their attitudes are just some the issues to take into consideration. And then there's some other services that can be offered, which are usually not as good, but of course we all know Google Translate, and we have all probably used it at some point. And then you can have multilingual signs, name tags, etc., etc. But I will mostly focus on the first part of the list. So again, sorry if this is chaotic, I hope it isn't. The way I conceptualize these scenarios for now, of course, this could be way more fine-grained, but for now I have categorized them in this way, are two scenarios, which I will then present, for spoken communication for speakers of an autochthonous minority language, and two scenarios for written communication, again, for autochthonous minority language speakers, and then the same thing for speakers of migrant languages. Of course, two main caveats among the many that we could probably mention. First of all, of course, I am aware that different minorities are incredibly different one from the other in terms of social linguistic situation and context, and speakers within the same minority are very different. And again, migrants is a macro category that comprises people with widely different life conditions, and also in terms of language spoken and the way that language relates to the language spoken in the host country. So of course, there is a lot of simplification here needed. And another thing that we may need to consider is that actually the boundary between written and spoken communication is not always that clearly defined, and that actually links back to a debate in social linguistics about how much sense it makes to consider the difference between the means of communication, so written versus spoken, as a dimension of variation. But that's just an extra thing to think about. Why do I say the boundary is not that clearly defined? Because for instance, someone could try to communicate with the patient, and if they are, for example, are at a loss for words, they may pull out automatic translation tools. So actually the two things often go together, and it's not that easy to clearly divide them. But I had prepared two examples. I will only show you one, but the kind of mechanism is the same. So I'll show you the example of scenario A and B, and I will actually only focus on scenario A for autochthonous speakers and spoken communication. So I thought about potential scenarios that we can have. For instance, we could have a scenario, for example, Catalonia or Saftaro, where by law, the staff should be able to use the minority language, which also has maybe co-official status or some kind of special status given to it. And in order to be employed, staff members, maybe permanently employed staff members, need to show proficiency. And the speakers have a right to receive healthcare through the medium of the minority language. While, for instance, scenario B could be a scenario like Northern Ireland, in which the knowledge of the minority language by the staff is not required. But I will only now focus on scenario A, and I do not expect you to read this. Sorry, there's the sirens again. I will just quickly talk you through it to give you an idea of how I organize this. So we have scenario A, right? So this is all scenario A, forget about scenario B. So this is all situations that can happen within a scenario in which by law, the staff should know the minority language, but I think we all know that doesn't always happen. And here we have a list of situations that are basically decreasing in terms, the more the list goes on, the worse it is in terms of linguistic unease, if that makes sense. And for instance, the best case scenario is that the staff is actually proficient, as they should be, in the minority language, and they employ it. And there could, within this scenario, we could have the active offer principle, which is the best case scenario we can have. And we can imagine that the consequence for this is no symbolic unease and no communicative unease. Or we could have a situation in which there is no active offer. Okay, maybe not as good because the patient needs to ask for it, which we saw is not good usually, but it's still there should be provision. And then going down the list, for instance, we could have a situation in B where only some members are proficient. Sorry, I'll finish in a minute. So only some members may be proficient, but there may be systems to, pair those who speak the language up with the patients who need it. So again, not ideal, but the level of unease shouldn't be too high, etc., etc. And going down the list, we see maybe a situation in which the staff is not proficient, etc., although they should. And so then there is a series of outcomes in terms of the degree of linguistic unease experienced by the patient. What did I mean when I said we need to look at this by also adding the layer of the social linguistic factors? I mean that all of these situations, I could have done it all in one table, but I thought that would then be even more complex to read. So the way that we need to look at this table is by also taking into account the three social linguistic factors that we mentioned. So to give you a very intuitive example, staff in situation D, staff is not proficient in the minority language, but they have an extremely positive language attitude. They say, for example, I'm really sorry, I do not speak the language, but I'm trying to learn it. I don't know. They are respectful. They have a respectful attitude towards the minority language. We can definitely imagine that this will have a positive outcome for the potential symbolic unease experienced by the speaker. Of course, that doesn't solve the issue, but it changes the scenario and it probably changes the perception of the speaker. So basically, you have to imagine this 8 times for the different scenarios that I have identified. Again, could be more. This was basically the same thing, but for migrants, but I will skip it. So I'll come to my conclusion. Sorry for going over the time. Basically, this systematization should be useful to identify situations of linguistic unease, as well as the measures put in place to address it. And this is then the basis to evaluate the design of relevant policies in terms of a series of criteria that I identified and that you can see here on the slide. And that's me. Thank you so much for listening. And sorry again, very last quote about the importance of, understanding the larger context of language when we think about language in healthcare. And that's us. Thank you so much for your attention.